Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Otsuka America Pharmaceutical, Inc.
Hello, I'm Dr. Jonathan Barrett, Professor of Renal Medicine at the University of Leicester in the UK. Welcome to this programme titled Translating Emerging Evidence in IgA Nephropathy, Proteinuria and eGFR as Biomarkers of Disease Progression. I'm joined today by my good friend, Dr. Brad Rovin. Hi, Brad. Would you like to introduce yourself?
Yeah, thanks, John. It's a pleasure to be here. I'm Dr. Brad Rovin. I'm a professor of nephrology at Ohio State University, Columbus, Ohio, in the United States.
Great. Well, let's get cracking. There's a lot to get through. So we both were in Glasgow at the recent ERA Congress, and we saw, as usual for IgA nephropathy, a lot of presentations. We had some new data on sibeprenlimab, some 12-month data from that interim analysis, and some new data for zigakibart. But in addition to those B-cell therapies, we also had the interim analysis of the ICAN trial of ravulizumab, the C5 monoclonal antibody, and that showed a significant reduction in proteinuria at week 34, suggesting blocking C5 is likely to be another therapeutic opportunity in this disease. But I want to bring us back now to the B-cell therapies. And first, just look at that data for sibeprenlimab. If we remind ourselves, we saw at the ASN last year some data looking at reduction in proteinuria at an interim analysis of the Visionary trial. And what we saw at the ERA this time was the GFR data out to 12 months for that interim analysis population. And as you can see on your screen, some very encouraging early signs that blocking APRIL with sibeprenlimab really does impact in a very positive way on the rate of loss of kidney function. And just cast your eye to the placebo group here, losing 5 mils of GFR on average at 48 months. So a significant loss of kidney function in that placebo-treated group. But when you add APRIL inhibition, that loss is significantly reduced. And so we're really going to be looking forward to seeing the full data set at 24 months, really to have a definitive idea about how much GFR protection we can achieve with sibeprenlimab. We also saw some data on another anti-APRIL monoclonal, zigakibart, this time studied in an early phase study. It was single arm, but it did have data now out to 124 weeks. So this is the longest period of exposure to an anti-APRIL that we have at the moment. And what we saw here at 124 weeks was a significant and persistent reduction in proteinuria in the pathogenic form of IgA-GD-IgA1. And interestingly, no loss in kidney function over 124 weeks with zigakibart in this high-risk IgA nephropathy population. And of course, what we're really wanting to see are the phase 3 data from the Beyond trial, which is the trial of zigakibart against placebo in high-risk IgA nephropathy patients. Brad, when you're evaluating these clinical trial data, what are you looking for in the proteinuria and GFR results?
So I'm really looking for the lowest proteinuria achievable. And, obviously you and I have both been using RAS inhibition for most of our lives. And now we're using medications that really decrease proteinuria by 50% or more. I'm really hoping to see proteinuria drop below an absolute value of 500 milligrams a day. So I always look for sort of the subset analyses of these trials to see what percentage of patients are getting down into that range, and even getting down into the range of 300 milligrams a day, whatever we sort of arbitrarily have defined as complete remission of proteinuria in IgA nephropathy. But the most important thing that I'm looking at is how these drugs affect preservation of GFR. And I think for the first time ever, we're seeing these drugs, the ones you just mentioned, the B cell drugs, are really showing they're preventing the decline of GFR compared to what's happening in the placebo group that's being treated for the time being with RAS inhibition. To me, that's the most fascinating development we've seen in IgA nephropathy, that we can actually not only slow progression because we have a lot of other agents out there, but we can actually seem to achieve zero GFR slope or no decline, at least over the period of time that these studies have been out there. So a year, 2 years so far.
So, Brad, when we're looking at the trial data, one of the things that fascinates me is you can see quite large reductions in proteinuria with drugs with very different mechanisms of action. But when you look at the GFR data, there seems to be a discrepancy in terms of the amount of GFR protection you get for a given amount of proteinuria reduction with drugs of different MOAs. What's your take on that?
Yeah, I think this is fascinating. And I think this really sort of points us in the direction, now that we have targeted therapies, that the way you actually reduce proteinuria may matter. In our previous history, reducing proteinuria was the goal. And it didn't matter how we did it. And of course, we didn't have very many options. But now, to me, and this is my opinion, in an immunologic disease, reducing proteinuria through immunologic mechanisms or targeting immunologic mechanisms may provide better kidney preservation than simply reducing proteinuria hemodynamically. So something that needs to be investigated, but really an interesting thought.
Yeah, I mean, I couldn't agree more. I mean, I think we were always interested in the difference between placebo and treated, and we're seeing striking differences in rates of loss of kidney function. But for me now, bearing in mind we're going to need to achieve on average less than 1 ml per minute per year for our typical IgA nephropathy patient for them to avoid kidney failure in their lifetime. What I'm looking for now is in the treated arm, getting as close as possible to that physiological aging of the kidneys. And you're right, I think with the B cell therapies, we're looking like we're getting tantalizingly close to that target. And that's very exciting for me as a nephrologist, but also I think very exciting for patients.
Absolutely. And I think, you say we want to get no more than 1 ml loss per minute per year, which of course I agree with. But the curves of some of these drugs actually suggest we're seeing a positive value to the slope with some of these B cell agents, which is also uh, physiologically fascinating to me.
Brad, I'm very jealous of you in the US because you have lots of new treatments available. You have Nefecon, you have sparsentan, you have atrasentan, iptacopan, and sibeprenlimab. And so when you think about that last patient that walked into your clinic, what are you going through your mind about the treatment choices you might have for them?
So I'm very much in favor of using the new medications up front. As you and your colleagues with the RADAR registry have shown, and it's been shown throughout the world, now in other ethnicities and regions, IgA nephropathy is a severe disease. And for most patients, it needs to be treated, and it's an immunologic disease, and so I want to treat it immunologically. So whether or not the patient is on RAS inhibition when they come to see me, they'll get put on that after an office visit for sure. But then I'm trying to get approval for a drug that intervenes in the immunopathogenesis of IgA nephropathy. And right now, the category of drugs that do this are really the B cell modulating drugs, the plasma cell eliminating drugs, and I think also we can include the gut steroids because they probably, or at least theoretically, are targeting the Peyer's patches. So I want to start with something to really control proteinuria, and I want to start simultaneously with something to control the immunopathogenesis of the disease. And then, of course, as you know, and you see the same thing in your clinics, most of our patients are coming, they've already had damage to their kidneys. We're diagnosing IgA nephropathy very late in the United States and in many parts of the world, I suspect, and they have chronic kidney disease. And so I'm going to start to think about modulating the chronic kidney disease at the same time. And I know I said we'll start RAS inhibition. That will help protect the kidneys, but I might look for something more to add, and that could be a ERA or a dual angiotensin endothelin antagonist. So that's how I'm thinking about the patients for almost every patient that comes into my clinic.
Fair, and I'm doing exactly the same, Brad. I just don't have access to the drugs you do yet. So very jealous over here in the UK. So one of the things that was really interesting that we were both at was a presentation looking at a meta-analysis of all of these B-cell directed therapies to look both at their safety and their efficacy. I wonder if you just take us through the highlights of that presentation.
So I think what's really impressive about the meta-analysis, and John and I were both part of this, is that this stacked up all of the B cell drugs. So that includes anti-APRIL, anti-BAFF-APRIL, and anti-CD38, wherever there was data available with a placebo-controlled group. And what's remarkable, at least at this point in our understanding of these drugs with the data we have and the time frame it's been given, these drugs are all looking to show very similar effects. These are also been subdivided into various groups, and it really didn't matter where the group started in terms of degree of proteinuria. It didn't matter the sex of the patient. It didn't matter the age of the patient. Geography didn't seem to matter. This worked well in patients of different races and ethnicities throughout the list of B cell modulating therapies. And something very important, for us to think about, since a lot of people are coming in on SGLT2 inhibitors for kidney protection, is that the presence of an SGLT2 inhibitor did not seem to impact the efficacy of these B cell drugs. So that's very exciting. And then when you start to look at GFR, uh, we saw similar benefits to GFR slope, again, throughout the compendium of B cell drugs. And what's remarkable to me is that when we look at the safety of these drugs, yes, they cause depletion of immunoglobulins. They cause, of all the immunoglobulins, IgA in particular. But we didn't see a safety signal that was very worrisome. We didn't see an abundance of infections or other adverse events. So I guess what I'm saying is, right at this point in time, the B cell drugs are hard to distinguish based on their clinical efficacy. They're hard to distinguish based on their safety profiles. And I think this really lends itself to allowing us to choose among these drugs for our patients. I think over time, as we follow the patients and the drugs on the trials longer, we may find some distinguishing features, but that's speculation. I don't know. What do you think about that? How are we going to differentiate these drugs, John?
I think it's going to take time, Brad. I think we've got fantastic data at the moment showing safety and efficacy. I think if a CD38 or a BAFF and APRIL compared to an APRIL, we're going to see differences in those modalities. I think it's only going to be apparent over 2 or 3 years. I do. And I think we just need to wait. But the great news is we've got choice for the first time, and we have multiple treatments that likely are going to transform our patients' lives. So for me, I think the data that I've seen really does reinforce the importance of these agents as almost a cornerstone or foundation of how we are going to approach IgA nephropathy in the future. I think we certainly do need more data. We need more data about how we might combine these drugs with other agents and whether there are certain patients that are going to do better with an APRIL compared to a BAFF and APRIL compared to a CD38. But that data will come. And I'm looking forward to going through that data with you, Brad, on another one of these presentations. What are your takeaway thoughts?
Very similar. I think what impresses me, as I just said, was the safety of these medications, because this really is where we want to go with our therapies. I mean, we've been treating all our glomerular diseases, IgA included, with high-dose glucocorticoids for a long time, inducing a lot of problems for our patients, both acutely and then chronic effects. And so far, the safety profile, not only of the B cell drugs, but even of the other drugs that are being used. The complement inhibitors have been remarkably safe. The gut steroids have been remarkably safe. The endothelin antagonists have been remarkably safe. Very exciting. And it really points to your question of, if we have good safety profiles, can we combine these drugs for even better efficacy? And I think that's a question that we'll have to tackle going forward. Um, so I agree with you. I think for me, doing this for a long time, this is really an exciting time for glomerular diseases and IgA in particular.
Couldn't agree more. And thanks, Brad. It's always a pleasure talking to you. Thanks for this great discussion.
Thank you for having me. It's been a pleasure.
And thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.